which is eligible for 1 credit from the ACI. Let's get started by giving one lucky attendee a Webinar Wednesday t-shirt for answering this trivia question. Today's sponsor, Accumen, is headquartered in Arizona. What is the name of the river that runs through the Grand Canyon? Answer now using the questions feature on your dashboard. While you're answering, I just want to remind everyone that our Spring MD Expo takes place at the Hotel Irvine, California from April the 20th to the 22nd. It will bring HTM professionals from across the nation for 3 days of learning, networking, and the latest advances in medical technology, products, and services. Registration is open and register for free using the code GOIRVINE, that's GOIRVINE. More details can be found at mdexposhow.com. Okay, and let's see who the winner of our Webinar Wednesday t-shirt is, and it's John Piscardi. Congratulations, John. Of course, the correct answer is the Colorado River. Webinar Wednesday would like to thank our sponsor, Accumen. At Accumen, their focus is healthcare performance. They share the belief that performance matters. They are inspired to improve operational, clinical, and data performance across the healthcare industry because transformational change will make healthcare better for their clients, their communities, and their families. For more information, visit accumen.com. Okay, our presenters today from Accumen are Dr. Carla Harmath, Physician Advisor, Imaging Operations, Stefanie Manack, Operations Manager, Imaging, and Judy Zakutny, Operations Manager, Imaging. Okay, Judy, you may begin whenever you're ready.
Thank you so much, Linda.
Good morning, everyone. My name is Stefanie Manack, and as Linda said, I am an operations manager with imaging here at Accumen. My background is as a technologist for about 15 years. I was a lead tech, an operating tech, a manager at several different health systems in the Midwest. My educational background includes an associate in applied science and medical imaging. I also have a bachelor's and a master's from Northwestern University, and I am thrilled to be with you today.
Thanks, Stephanie. This is Judy Zakutny. I'm also an operations manager of imaging at Accumen, and my background is also as a technologist. I'm a retired technologist that held advanced certifications in CAT scan and MRI, and have over 35 years of experience in both the imaging departments, from a tech all the way through a system director, as well as in the IT side of things. And I'm happy to be with you here today as well.
Hi, everyone. Good morning. My name is Carla Harmath. I'm a radiologist, and I'm currently the Chief of Abdominal Imaging at University of Chicago. I am a physician advisor for imaging here at Accumen, and glad to be with you.
All right, let's get started, and I'd like to turn it over to talk about the learning objectives today, which are how to efficiently and effectively find the common data language when speaking with stakeholders, how to ask the right questions and translate data requests into the language that meets your goals by getting to why, and how to successfully communicate using the right language with consultants and outside influencers to accomplish your data goals. Let's go ahead and get started. Stephanie?
Thank you, Judy. So those of you that are attending the webinar might be asking yourself, why a webinar topic on this, and what does it have to do with me? It's not maybe a typical topic for a webinar, but stop for just a moment and think about how much of your job depends on data. And the more responsibilities you have, the more you likely rely on data. Patient schedule reports from the EMR, data. Your budget cycle every year, data. Volume reports, labor reports, inventory planning, forecasting your capital purchases for your 3, 5, 10-year plans. Everything starts with data. And the radiologists that you work with depend on data as well.
Exactly. Even though we don't think so much about it, Stephanie, we're all measured using data. So do we really know exactly what is being measured, though, or how those measurements reflect on our practices? So understanding the data is very important. If you're an academic radiologist, for example, you don't want to use the data that reflects the expectations of a private practice and vice versa. So knowing the data alone does allow people to compare apple to apple. So understanding where's the data coming from and how to use it is imperative. And it's important to understand because that allows you to see where there's room for growth or change.
Absolutely, Carla. Data talks, right? And data is the source of truth, whether you're evaluating your operation, identifying opportunities, minding your budgets, your operational goals and metrics, as well as your own professional goals. So this still picture, many of you might recognize from the comedy classic Who's on First with Abbott and Costello. And as a side note, if you've not actually seen the original, YouTube it because it's hysterical. But this skit, actually, Who's on First, is a great example of what can happen when you're using the same words, but the words mean different things to different people in the conversation. In this particular sketch, who is the question, but it's also a person's name. And of course, what makes the whole thing funny, right, is that we're looking in on it, and we know what the problem is. We're watching it unfold. But in that moment, when you are Costello, for say, the frustration and the angst of not communicating clearly can be absolutely maddening. Imagine the outcome if all the details are clarified right in the beginning. We wouldn't have this amazing comedy sketch, but the frustration and the angst would be really short-lived. Clear expectations and communication that clarify, resolve any disconnect and miscommunication, and often before it actually becomes a problem. And in this bit of comedy gold perfectly illustrates that they were saying the same words, but not actually speaking the same language.
That is so true, Stefanie. This Abbott and Costello skit is a great example of how simple words had different meanings to different people. Communicating with coworkers is a significant part of our everyday lives, and we rely on that communication to get things accomplished. Miscommunication is therefore also part of our daily life, and it tends to occur at all levels of the organization. You know, no one wants to feel like their time has been wasted. Lack of clear communication and failure to get your message across leads to mistakes, altered project directions, and rework, just to name a few. But most importantly, it can lead to a non-collaborative environment. I'm sure many of you can think about projects you've been a part of and how miscommunication adversely affected them. David Grossman had a report called The Cost of Poor Communications, and in this report, it stated companies with 100,000 employees each cited an average loss per company of $62 million a year because of inadequate communication. Also, the report cited a business with 100 employees spends an average downtime of about 17 hours a week just clarifying communication, and that equated to $528,000 annually. In everyday life, the need to clarify this communication occurs. And there are many words in the English language that have multiple meanings, and then we also have slang meanings. So for example, a friend got engaged last week. All of you are very engaged in our presentation. If I say the manager was out sick for several days, it obviously means he was out ill. But if I say Bob drives a sick car, it means his car is really amazing. So you can see these words with different meanings are very prevalent in our everyday lives. And I just mentioned earlier about the pitfalls of not speaking the same language. We need to recognize that words do mean different things to different people and avoid the issues this can cause. Now, healthcare has its own language, but even inside healthcare, imaging has its own language, and we may not be speaking the same language. So let's talk through several examples and find out what language each of you is using. It's going to help us realize the importance of using a common terminology.
Thank you, Judy. So when we think about the language of imaging as it relates to data, productivity and throughput tend to be the first things that come to mind, at least for me. They're very data-driven, data-heavy parts of our business. And each of these pieces require very specific and precisely defined data. It doesn't matter what you're measuring or analyzing. How effective that measurement or any improvement plan are is going to hinge on knowing exactly what data is used and how it's represented. For example, let's take productivity for a moment. So productivity is defined as the ratio of time invested in a process versus the time expected for that process. So it's a measure of the time that it takes to do work. I'd ask you, what do you mean by the time that it takes? Are you using productive hours only? Are you including non-productive time? Or maybe the labor report you're using has total hours paid, which would include productivity, which would include things, like PTO and sick time. If you're using a data set, do you know what the numbers in that data set represent? For the time expected to perform work, you could be using a detailed actual time that an exam takes at your institution, or you could be using an average, like what might be built into a scheduling template. Each measure on each side of this equation, the denominator and the numerator, are going to give you a different representation of productivity. And the same thing is true with utilization, right? So that's the effective use of a resource. And I think for us, often it's a measure of things like capacity optimization. If you have a template in an apartment with 30-minute appointment slots and every slot is scheduled with a patient, you have 100% utilization, correct? Well, maybe not. Because if the average time it takes to perform an exam is only 10 or 15 minutes, you actually have quite a bit of unused capacity. Half of your schedule time of a template is underutilized. It kind of brings us to cold table time. Before you even define the data points, you need to define what is it you are measuring. Is it the time that your scanner is unscheduled? We spoke a moment ago, like unused capacity. When I was running the IR department, it actually meant how long it took for the team to turn a room around in between patients and patient appointments. So even before you define the data that you're using, it's very important to define what it is you are actually measuring. Turnaround time, that period of time that it takes to complete a process, this one will also get very muddy until the actual process, and then the data points are clearly defined. And radiologists also have lots of metrics around productivity and throughput, and they suffer from the same problem. What is being measured and how?
Exactly. I have a few examples that come in mind, like, for example, regarding turnaround time and what it specifically means has to be clear to all parties. We must understand what is measured and how it's measured. Turnaround time could mean, for example, for a radiologist, the time that she or he opened the exam, the time he or she finalized the report. However, to the administration, it may mean the time that the exam was ordered to the time that the report was completed. So the two are very different. While the radiologists do have some control over the time we use to, dictate a report, scheduling, time of arrival, scanning and sending the exam to PACS are out of our control most of the times. So if the administration is including those in your turnaround time metrics, it's very important to know and make them understand what is your participation in that metric. The data can be used and adapted to best reflect how your practice works. It can serve as means to improve quality. If turnaround time in your practice is too long, there may be ways to improve it. From the administrative side, for example, how efficient are the techs? Do they have a tech aide, a nurse, or do they navigate solo? Investing in some aid may decrease your turnaround time, increase your productivity, and improve your revenue, for example. Not different for the radiologist part in it. Is your PACS user-friendly? Do you get constantly interrupted? How can you improve these? Can AI, for example, improving protocoling and coding, for example? So data can be very helpful if clear and well understood.
Absolutely true, Carla. And in all of these cases, it is imperative to clearly define exactly what you're trying to evaluate and understand all the various data points and what they mean. And if you're going to successfully assess the current state of your operations and uncover any areas of opportunity. So let's take a moment and turn our attention to finance.
Yes, the financial aspect of our job has a direct relationship with productivity, for example. Physicians' productivity is measured by relative value unit or RVU. However, how each person understands RVU, the RVU meaning can vary a lot. In the radiology world, sometimes it's related to the value assigned to the type of modality you read. Like, a CT has a certain point value, but sometimes it's the theoretical monetary value that is assigned to that RVU that certain payer provides, or how much the institution collects per that RVU. We have to understand what exactly people are meaning when they talk about RVU. Important to be very clear. Not only most practices revenue is tied to the RVU, but some practices actually tie the employment agreement with the radiologist compensation to a specific percentage of the RVU, for example. And you have to understand what they're talking about and what or how much is collected and what is that monetary value. So again, speaking the same language is imperative.
Yes, absolutely. And then looking from the imaging director and manager side, cost per procedure, what does it mean to you? But then you have to stop and think, what does it mean to your finance department? For you, is it the labor and supplies it takes to perform the procedure? On the finance side, is it defined as direct and indirect costs? But what's the definition of direct and indirect costs? What things are included in each of those buckets? From the finance perspective, a lot of times they'll look at an average cost across all modalities as the cost per procedure, just to get an idea of how things are going, versus looking at the cost per individual procedure. And then looking at volume, you have to stop and think, is the focus operational, or again, is it from the financial perspective? Is it being defined as the revenue the procedures are generating? Therefore, if it is, the assumption would be the billable volume totals are being counted versus the number of procedures being performed. If you're looking at it from an operational aspect and looking at those performed procedures, you have to take things into consideration, such as what you consider a chest, CT, abdomen, and pelvis. Is that 1, 2, or 3 procedures? And then let's talk a little bit about labor spend for your department. If you're looking at this and trying to calculate this, are you using both productive and non-productive hours? Are you even able to differentiate between the two in your data? Do you understand what pay types are flagged as productive versus non-productive? It's important to clearly define what you are trying to measure. You could be looking at maybe agency staff wanting to determine the agency labor spend, or be using the labor data to determine productivity and want to use just actual hours worked to determine this. Again, you have to define the makeup of the productive hours. This could include regular, holiday worked, overtime, PRN, and you have to do this so everyone involved is on the same page. Now, when finance is determining the labor spend, they typically are using all paid time and fully loaded salaries, meaning including benefits. But again, this isn't something you should assume. And lastly, looking at encounters. At your facility, are they defined as a single patient visit to your organization? Or you may have sub-encounters for ancillary services such as anesthesia. So these encounters can have different meanings. It is so important to understand what this information is being used for, what data is being used and why, especially if these reports, such as the financial reports, are generated outside of your control. Let's talk about a few operations examples.
Thanks, Judy. So for operations, you would think that this would be a little bit more straightforward maybe than productivity, throughput, finance metrics, maybe not quite as data-driven, but I'd argue that point actually. Think about if you're trying to do a project and you're measuring patient access issues, right? You might need some of the data points that you see here on the screen: appointment time, arrive time, start and end of the exam, exam duration. But let's just think about begin and end time of an exam for just a moment. What is that timestamp a reflection of? Is it the total time that a technologist takes to perform an exam, including perhaps getting the patient and all of the post-exam requirements? Maybe there's paperwork, they have to walk the patient back. Maybe there's post-processing that needs to be done depending on the modality. Does it include the time it takes to clean the room and get it ready for the next patient? Or in the data set that you have, is it strictly a measure of the time that the scan itself takes?
Yeah, it's funny, talking about operations. Most radiologists I know, and even me a few years ago, didn't think that I had any control of operations or that I was even a part of it. But there are several factors on our day-to-day jobs that direct affect operations. For example, having the correct exam protocol prior to the patient arrival allows for pre-approval from the health plans, spares technologist time and ancillary staff time. Also, this will add to overall patient satisfaction. This is all part of operations, how things are happening. Exams performed timely and smoothly once we have the correct protocol in place. As our time is short and valuable, things that we can think about operations in our standpoint is, can artificial intelligence or softwares help and allow better protocoling and operational assistance in that? So there's definitely a part of the physician's day-to-day job that goes into operations. For those of us doing procedures, there's even a more direct effect, I think. Knowing ahead of time what is going to be biopsied, for example, spares that timing on the table. And if you know what you're doing, you're not going to need to spend time making phone calls and looking up the patient when the patient has arrived. Another idea, that is part of operations in the sense is linking the biopsy schedule to the laboratory work, for example, that will confirm that things will be ready to run as scheduled. A way of ascertaining that the patient will have the adequate laboratory workup prior to procedure could include a flagging system between the radiology scheduling and the laboratory workup in the electronic medical record, for example. When the patient is scheduled for a biopsy, he's also automatically scheduled for the laboratory work. So this is part of operations that can be optimized and that, are actually within our reach as physicians.
So the things that we've talked about, the throughput, operations, finance, each of these data points and the very granular definition of them is going to tell a different story. What story are you trying to tell, and do you have really the correct data points to do so? And defining operational terms ahead of time is equally as important as productivity, throughput, and finance. And now, a word about benchmarks.
So the definition of benchmarking is a standard way of comparing one product to another. But is it really standard? Are we speaking the same language when it comes to benchmarks? Who are you benchmarking against? Other facilities that maybe use the same benchmarking product, other facilities that may be similar in size, bed size. Many times this is used as the criteria for the facility comparison. But you may be similar in bed size, but your case mix, your services offered may be vastly different than the facilities you're being compared against. So to me, that really doesn't seem to be an accurate comparison. Take productivity, for example. As Stefanie pointed out, there are multiple methods that can be used to determine productivity. So you have to know what metric is being used and how it's being calculated in the benchmarking data. Also, one thing to determine is how the percentiles that are reported are being used. I've seen different methods being used for this. Many use that the higher percentile demonstrated means that you are better than the majority of the people you're being compared against. But I have also seen the opposite philosophy, that being in the lower percentile, for example, in the 25th percentile, shows that you have performed better than the majority. To truly benchmark, the same methodology must be used. And this is not only true when you're comparing against internal and external facilities, but as well as when comparing to yourself. Carla, can you touch a little bit on how benchmarking applies to the radiologist?
For sure. Now, we collect data. We have all the data, but what does it mean and how can we use it? So I think this is when we apply the benchmarks. Basically a way to see where we stand in comparison to others. However, the one caveat is that we need to use the correct benchmark to our practice. Once again, one cannot connect or compare an academic radiology facility directly to a private practice radiology group, although it's always advantageous to understand the difference between the two because there's some co-applicabilities. But also understanding that a small, 80 to 100 bed hospital cannot be compared to an 800 bed hospital. So expectations are different and benchmarks are going to be different. So you must understand what the benchmark is measuring and be able to use the benchmark that closest approximate to your reality. So let's say you are the only radiologist reading MRI in your practice and the exams are performed over the weekend, but hopefully you're not the person on call every weekend. You may end up reading MRIs on Monday that are over 48 hours old when you come to work. So that does affect your turnaround time. Now, if your practice benchmark for turnaround time is 10 hours, for example, your curve is already shifted when you get there on Monday. So you're already behind. Understanding the benchmark, what the benchmark is measuring, is how it's going to reflect your workflow. And that's super important because you may need to adjust that benchmark to reflect what you're really doing. So either you use the data that adequately fits what you're using and adjust that benchmark to that. So if you do not have the correct benchmark to reflect your data, you're not going to get there. So having the correct data and understand how you're using to your practice is imperative.
Absolutely. And now thinking back on all the examples we just talked through, it's apparent that different languages as well as methodologies can be used and are used. Ensuring a common language and methodology is being used is the key to true benchmarking.
And I would argue that having a common language when you're speaking about data inside your organization is key to your operations as well, right? So if everybody is using the same data and everything is clearly defined, it improves collaboration for sure and helps to facilitate a clear understanding. So I know that what I'm talking about and what you are talking about, if we're using the same words, we are also using the same definitions and meanings. Establishing that shared dialect provides consistency across shared data. If you think about a larger organization, you may have 3 or 4 sites in your organization or many offsites as well. If you're sharing data sources, everyone needs to have a clear understanding of that data source and what it means. Another key point to remember is that imaging is not the only one with its own unique language.
Absolutely, Stefanie. It's a very good point. This not only affects imaging, as we've seen, but the other teams you're working with on your project, as they may have their own unique language. Folks outside of your organization, such as consultants, may be part of your team, so they too will have their own language. Take, for example, the data team. They will tend to use the term delta to define the difference between two things. But to a clinical person, delta isn't typically a word used in our world. So I think to a clinical person, the use of variance would more likely be understood. On the finance side, though, I've seen that described as either a favorable or unfavorable variance. And then thinking about acronyms, they're used quite frequently in healthcare, as we all know. Take, for example, RT. Folks could take that to mean respiratory therapist, but probably all of us on the call, the immediate thing we think of is radiologic technologist. And then looking at AUC or AUC means appropriateness use criteria for many of us, but to an oncology nurse, it could mean area under the curve. Thinking about CDM, what comes to mind to you is probably charge description master. But in healthcare, it can also mean chronic disease management or even clinical data management. With these examples, you can see that between clinical teams, as well as between clinical and non-clinical teams, interpretation of these words is different. This can adversely affect the outcome of your project if not clearly defined and understood by all involved. One thing to also keep in mind, though, is if the project is being done at all the facilities in your health system, there may be different project teams at each facility working on the project. You absolutely need to ensure the same language and methodology is being used at all these facilities by all the different teams. By honing a shared common language, you will build trust and supportive collaboration across these different teams, but just as important, you're going to remove any misinterpretation. We have to be open to learning these different languages, but then utilize a common shared language for the project.
One mistake I think I see frequently, and I think we all do see frequently, is assuming that the language is clear, assume that we do understand it all. So there is a concept that I learned the other day that, concept of teaching back, letting the other party explain what exactly they understood does allow for clarification and confirmation that we're all on the same page. And I think this is important to be used.
Oh, for sure. And I actually have a little bit of a confession to make at this point. I found myself sometimes getting frustrated enough or getting confused enough with things that I would tell the data team or the data analyst I was working with, just give me the whole report and I will take from it what I need. And there might be one or two of us in the audience who've also done this before. I would offer that that's actually not very helpful. For the biggest reason is it doesn't solve the problem that we've been talking about. Defining of the terms that are used and if they line up with what it is that you think they mean. Just because you have the whole report doesn't mean that you know when it says, productive hours, you don't know from that column what productive hours mean, where that data came from. And quite honestly, collaboration and getting rid of silos is definitely part of the goal of communication in healthcare. Judy talked about this earlier. This approach actually runs very counter to that goal. So you have taken the time to define a clear data points in your common language. So what's next? Now you can accurately and confidently move on to that very important next step.
Absolutely. And what we think we want and what we truly want are two very different things. And this statement really rings true when you're defining your project objective as well as the end goal. As Stephen Covey said, begin with the end in mind. You need to begin each project with a clear vision of your desired direction and outcome, and then you have to make it happen. And this applies to all aspects of department analysis, including the radiologist metrics. Starting with and defining using a common shared language, as we've spoken about, is key. This is the foundation of your project. Having the same understanding by all project team members of the problem trying to be solved will guide them throughout the execution of the project. The team is then going to be on the same page, speaking the same language. And then you have the team speaking the same language. You can then define the metrics needed to accomplish the objective and reach the end goal. What exactly are you trying to measure? Maybe volume growth year to date, revenue generation per site, and then what is the best approach to do this? The purpose of the metrics is to provide accurate performance measurements and a window into opportunity that may not be readily apparent to you. This in turn is going to allow you to drive change. Keep in mind though, a good metric is one that correctly describes the current state, does not allow for human manipulation, and helps you achieve that holistic view. Also, incomplete data or small sampling may skew the outcome. You have to be confident in your data that it's accurately representing the results. You want your audience to also be confident in those results and not mistrust it. If they do, this can block progress on any action being taken. And then lastly, including upstream and downstream analysis. Other departments' language and goals can have an effect on your project. Take, for example, the end goal of reducing the turnaround time for emergency department patients, for example, from order to exam complete. You have your imaging department goal, but does it coincide or differ with the goal the ED department may have? The ED department may have their own goal to reduce the time from order to patient available. In many instances, maybe they're marking the patient available way before they're actually available, obviously then totally skewing the imaging turnaround time data. With cross-department collaboration and defining a common language for the meaning and importance of the timestamps, along with defining a common goal of accurate turnaround times, will allow both departments to precisely determine if there are issues, and they exist, what they are, and how to make improvements. So let's summarize. If you can't explain it simply, you don't understand it well enough. Albert Einstein said this, and I think this quote really sums up the points we've discussed thus far quite well. When we think we are communicating to be understood, we may not be. It seems easy enough. You know what you mean. Why wouldn't everyone else know what you mean? The importance of comprehending the need and using a common language cannot be understated. A problem clearly stated is a problem half solved. And one way to do this is documenting the meaning of data fields so all team members are on the same page. Let's now talk about a way to reduce those language barriers. Stefanie?
I am so sorry. As Judy stated here, a problem clearly stated is a problem half solved. And the problem clearly stated is that there is an often overlooked, and most times I would argue we are unaware of the language and dialect barrier when you're collecting and analyzing the data that you use every day. One simple solution actually is to create a kind of a glossary, a standard document that can be used both as a reference for yourself and as part of a project plan or a kickoff meeting. For this project and what we are measuring, volume means performed procedures only. Or for this particular metric, we need to look at all build volume when we say volume. It's a very simple tool, but I'd argue it's a critical tool to defining the terms and the common languages for the data points that are going to be used for this project or this report. All of this really is about bridging that gap, right? The gap and the language barriers that you now see likely exist on the teams to ensure that your projects are successful and that the reports that you're using and the data that you're using truly means what you believe that it does. We've talked about how to set a common language and then use that to determine your metrics and gather the data that tells the accurate story of what you want to measure or study or improve. The next step is getting that right message to the right team in the right way to get the buy-in and support and engagement you need.
Yes, and to do this, you need to make sure you are using the right medium to convey the results to multiple stakeholders. This quote is a great example of why that is so important. As a manager, it's not your job to crunch the numbers, but it is your job to communicate them. Never make the mistake of assuming that the results will speak for themselves. Choosing the wrong medium, such as the type of graph, having way too much information, can lead to misrepresentation of that data and the inability to deliver the results along with your message. Don't try to be everything to everyone, but absolutely know your audience. They may not share the same background. Craft your message using the right medium. Using that right medium to present your message can make all the difference.
Definitely, and this applies, I guess, to everything we do. When giving lectures, for example, as radiologists are conveying research reports, grant applications, the way we display and convey the data has to be clear and has to be able to explain your findings and your goals.
Yes, and Marshall McLuhan said it best, the medium is the message.
Such a simple and true statement. Anytime that you're presenting data, your data should really touch on these 5 things, right? You need to show a clear understanding of the problem or current state and convey that to your audience. The impact, why is it a problem, right? You also should be able to show your plan to improve, to make the changes and what impact that plan of change is going to have on the area that you're looking at or on the metric that you're trying to improve. You should also, to Judy's point earlier about upstream and downstream effects, you should also show any additional benefits that could come from solving your problem, any upstream or downstream pieces. And so let's take a look at some examples of how to convey your message to an audience and how not to.
So looking at this example, do you understand the message it's trying to convey? There are a lot of pieces of the pie here, making it extremely hard to read. The labels overlap the pieces, so you're not quite sure which label goes with which piece of the pie. The colors are used over again, so that's confusing. The pieces actually add up to well over 100. Now, there is a legend, but it's not really clear. What exactly is the scale? 1 to 30% maybe, or number of prescriptions? It's overall just not visually appealing, and it's a wrong pie chart to use for this type of information. Now, this is a great example of using a pie chart to communicate the message effectively. You see the categories, they're easily discernible. The portions of the pie are distributed appropriately based on the percentage they're representing. You clearly understand the scale, visually appealing, and the message is very clear.
So let's take a look at this particular graph. What is the message of this one? And just for a moment, you tried to read this from left to right, didn't you? I did. That's actually an example of something called a mental heuristic. That's a shortcut that your brain's going to take to help you try to quickly synthesize information. And you tried to read this left to right because we all know that a trend line chart is, in theory, shows a change in a value over time. So let's look at this. There's no legend to speak of. The left axis values are 1,000 to 8,000. 1,000 to 8,000 what? We have no idea what those values on the left side mean. And across the bottom, the indicators are not time-based either. So my first question, what time is poker? If this is supposed to be a trend line chart that shows a change over time, what time is poker? And what time is cribbage? Bridge has a value of 1,000 on Sunday and about 1,750 on Wednesday, but a value of what? The proper way to use a trend line chart is to show a change in a value over time, like this. I think it probably took about 4 seconds to synthesize this information, and it's because we're using the correct type of chart to show information, right? There's a title, cost per test, so you know what it's trying to show. And although there's no legend for the axis on the left side, there's dollar signs and decimal points. So you clearly know that it's a dollar sign, a monetary value over time that's being shown. Very clear values on both axes. It doesn't need a legend. That's how clear it is.
And I think even during conversations with the leadership, for example, if you cannot clearly demonstrate the data you collected and what it means, you'll probably not be able to convince them of your needs and plans for improvement.
Absolutely. So keeping these examples in mind, both good and maybe more importantly, the bad ones, ensure that you are presenting the right message using the right medium. And the message is going to change based on who you're presenting it to, right? So if you're presenting a message to your stakeholders, you need to be mindful of those cognitive heuristics of what the expectation is when you visually see the data represented. It needs to be clear and concise. For your high-level stakeholders, you probably need less detailed descriptions and analysis and more impactful and high-level information. If you have to explain your chart to other people to get them to understand what it's saying, as Judy alluded to earlier, you run the risk of losing your audience and of losing your support. Information your stakeholders need is going to be very different, though, from the information that your team needs.
Yes, it will. And your team really knows the inner workings of the department, which provides a tremendous advantage in fleshing out the data needs. They too need to know why the project matters, the impact and benefit it will have on them, the department, as well as the patient. Talking to them about the forest and the trees is essential for attainment of the goal. Knowing what they're working towards and the detail that goes along with it will get them on board to arrive at the necessary destination and ultimately help you drive change. The right message is also, though, needed for your project partners.
Absolutely. And the message your project partners need is going to be about halfway between the detail that you need to provide your team and the more high-level approach you need to apply to your stakeholders. And the why is important for your project partners, right? More detail than your stakeholders have can be helpful in that their goal is to help you connect the dots, right? If they understand the why, they can help decipher the data points with you and help make sure that you are getting the data that you truly need. And that partnering and fostering of collaboration will absolutely have positive effects.
Totally, Stefanie. And again, the corrected message and the means used to deliver it really allows for transparency, collaboration, and overall satisfaction. And I think once again, we have to turn back to our friend Albert Einstein for a very nice quote.
Yes, and he said, a clever person solves a problem, a wise person avoids a problem. Be that wise person and avoid the pitfalls we've spoken of earlier by using a common language as the key to unlock your project potential. Successful projects will become a reality, paving a way to accomplishing your goals and driving impactful change.
Absolutely. And that's part of what we do at Accumen, right? When we partner with you on any imaging project or transformation, defining that common data language is one of the very first pieces that we work on together. Breaking down the reports, any benchmarks, metrics, and such that you're using and that we would use with you to help you into a common language to make sure we're all on the same page. This foundational step is absolutely critical to ensuring that together we can drive meaningful change for your organization. I'd like to take a minute to thank everybody in the audience, as well as my colleagues, Judy Zakutny and Dr. Carla Harmath, for taking time to put this together today. And before we open up the floor to questions, if you are interested in practical application of the things that we talked about today, Judy and I will be presenting at the AHRA conference in Boston, an interactive session on how to take these things and take this knowledge and apply it to some of the things you probably use every day. And thank you again for taking time with us, and we'd like to turn it over to questions.
Great, thank you so much, Judy. Yeah, we've got a couple of questions here. The first one is, earlier you mentioned benchmarking programs and the issues that it can cause. Are you saying we should stop using them?
No, not at all. Benchmarking does have its value, but again, it's so important to know exactly what data and methodologies are being used in whatever system that you're using, so you understand what's being measured, how it's being measured. As we spoke about productivity as an example, do you know what data is being used and how it's being calculated? To me, the best way to benchmark is to benchmark against yourself, so you truly know if things are being changed and you are making those appropriate changes and trending over time.
Judy, I agree. You mentioned a point earlier, I think that's super important here, is about comparing to like organizations. And it's something that's much more challenging, I think, in imaging than it is perhaps in other service lines. But what does that mean, right? I also agree that it's things like bed size or annual spend in dollars, net patient revenue, that kind of thing, might not actually be a really precise gauge of who you are like in an imaging department, right? It might have some bearing on the overall organization, but I think it's less specific to imaging. It's not a matter of any metric or system being correct or incorrect, or one benchmarking thing being right or wrong. I don't think that's at all what we're saying. I think what we're saying is that you need to know how the metric is being calculated and measured so that you understand that measurement and how you are being evaluated against it. To just say things like we are in the 75th percentile for productivity, or we are beating our benchmark marks for hours worked per exam, I don't know that they have a whole lot of value otherwise, right? Not enough value that you could use operationally to make change.
Okay, that's great. Well, another question is, I can see just how much of a problem it can be if everyone is not on the same page and obviously speaking the same language, as you mentioned. But how do I get people to give me what I need for my projects without having to go through this each time?
Well, I think I failed at it before. I think I mentioned in the presentation, I have made the mistake of saying, just give me all of your data and I'll take what I need. The work up front to really talk through a project with the team members, making sure that everyone understands the goal, what you're trying to show. I mean, it's really key to the whole project, right? You need to know what you're measuring and how to measure it. It's about taking that extra step at the time to ask the questions that, frankly, a lot of us never thought to ask of before. I certainly didn't originally, right? This column says volume, but where did that come from and what does it mean? Is it all billable volume? Is it your procedure volume? Is it patient count, right? Is it a patient volume? I'm a big fan of things on paper, so creating a cheat sheet or a glossary that can be reused is kind of a simple way to ensure that first you remember to get clarity on the data points. And then also I think to ensure that the definition and the data points that you need are what can be provided, right? And what they're needed to accomplish your analysis. Sometimes that does take a lot of extra conversations to clear it up, but the increase in collaboration and understanding is exponential. Not to mention you'll actually get what you need to push your project forward.
Okay, great. Another question here. Wouldn't it be easier just to tell the data team what I want? For example, I need procedural volume only or worked hours only.
Well, I think that's the point here is, do you have to first ask, do you know for sure that the data analyst understands what you mean when you say procedural volume? Do they have any idea that it is truly the procedure volume from the wrist versus all billable CPT volume? So you have to make sure that they're on the same page, speaking that same language. You want to make sure that you're getting the data you need. You're getting enough of a sample, as we spoke about earlier, so you're not taking too small of a sample to skew the data. And it also allows you to all get on the same page, speak the same language, make sure there's collaboration and a clear understanding of what you need and making sure that the data is correct that's used in the report.
Okay, that's great. Thank you. We don't seem to have any more questions, so time is creeping up on us, so I will wrap up now. So thank you, ladies, for a great and informative webinar, and obviously thank you again to today's sponsor, Accumen. Just a quick reminder that the post-webinar survey and certificate process is automated, so the survey link will be included in the follow-up email, which you'll receive in about an hour's time. Once you have completed the survey, you'll be able to download your certificate immediately. If you have any questions, please contact us at webinar@mdpublishing.com. And for more information about all our upcoming webinars, please visit our website, webinarwednesday.live. So thank you once again to everybody for joining us today. Enjoy the rest of your day, and we hope to see you next time.